Hello, and welcome to my SCAT6 presentation. As I go over this, I'm going to be explaining things, giving insight into what it actually is as an assessment tool, but I'll also be conducting and reading the instructions out loud. But I'll make sure to go over it and explain it as I'm doing it. So the first section that you'll see when going over the SCAT6, and it's very important to fill out, not overlook, is the patient information. So in order to begin the assessment, we just want to take general information down, such as name, date of birth, time of injury, dominant hand, these type of things. And that just overall will help keep a cohesive documentation as you go forward. So as you can see there, that's what it would look like blank, filled out like this, like I said, including the athlete's name, school, sport, year of education, along with any type of concussion history that they've had in the past. It's important to document concussion history because it can play an important factor later into their symptoms and their recovery time. Moving forward, steps one and two. So, in the SCAT assessment, step one is the observable signs. Now, this can be done through a witnessed, actual on-field event, as you saw it happen, or it can be seen through the video. And as you can see, there's multiple questions asking yes or no, and you have to indicate yes or no depending on what they're asking. So if you see that the athlete, when the incident happens, is lying motionless on a playing field, you'll answer yes. If it's a no, then you'll answer no. This is something that you don't have to have the athlete there or physically asking them. You can do this yourself. And also, like I mentioned before, you don't have to be there also to fill this out. You can have seen it on video and you just have to check the recording box. Following that, you'll also complete the Glasgow-Coma scale. Now, this scale is kind of broken into three separate sections, one being the best eye response, one being the best verbal response, and the other being the best motor response. Now, it is important to also include the time of the assessment and the date of the assessment. So if you're responding to the incident in person, you would put the time that it happened, and you also put the date that it happened. And then according to the findings you have, you'll fill it out. So for ours, as you can see, moving into that, we had 4, 5, and 6, which are all normal responses. The eyes open spontaneously, the patient was oriented, and the patient also obeyed commands. Moving back to the observable signs, we witnessed it in person as well. The patient did not lie motionless. They did not fall unprotected. They had minor balance gait difficulties. There was no disorientation, no blank or vacant look, no facial. There was slight facial trauma. There was no impact seizure, and it was a high risk mechanism of injury. I'm moving into the box one, which is not part of the SCAT6 assessment, but something that they put into the assessment so that you can see it as a clinician. And these are the red flags that you should be aware of. So the patient should be continuously monitored, obviously, and asked whether they are experiencing any of these things. And along with that, these signs and symptoms and these red flags should be made aware to the patient's parents, if that's who's looking after them, their roommates, if they're living in a dorm or in college housing with teammates. These things should be made aware to other people because these are red flags that could be life-threatening conditions, such as, the loss of consciousness, vomiting, deteriorating conscious state, things of this nature. So steps 3, 4, and 5 kind of go quickly. The kind of shorter sections here. So first one is step 3, which is the cervical spine assessment. And this kind of can be easily broken down by reading the prompts. So does the athlete report neck pain at rest? Is there tenderness, palpation? If no to both of those, are they moving around? Moving on to step 4, you can see that's coordination and ocular motor screens. Is a patient able to take the finger and nose normal for both hands while eyes are open and closed? Are they able to do it without moving their head and neck? Can the patient look side to side, up and down without double vision? Moving into step 5 is the memory assessment, Maddox questions. So these are things that you see a lot in movies and that sort when they just ask what where you are. So what venue are we at today? Which half is it? Who scored? What team did we play last week? Things of these natures. And these type of questions are being asked to see for amnesia and testing for retrograde specifically. So as you can see in our example, we went up to the athlete, we asked them if they had neck pain. They reported no. We went up to the athlete and also palpated. There was no tenderness. There was no neck pain or tenderness. And the athlete had full active pain free range of motion, so we indicated yes. And limb strength and sensation was all normal. So step three was no, no, yes, yes. Going to the coordination ocular motor screen, it was all three yeses there. There was no indications of any abnormalities there. And then going into the step five memory and assessment max questions, we would look at the patient and we would read from the prompts. We would go, I'm going to ask you a few questions. Please listen carefully and give your best effort. First, tell me what happened. And then we would go into what venue are we at today? They answer correctly. Which half? They answer correctly. What scored? Who scored the last in the match? They answer correctly. What team did you play for last week? And they answer correctly. And then did your team win the last game? And they also answer correctly. So they got 5 out of 5. So this section kind of gets broken up into little steps. So this one is the off-field assessment specifically. And we go on first into the athlete background there. So as you can see, we're looking at to see if they've ever been hospitalized for a head injury before. They'll indicate yes or no. We're also looking at if they've been diagnosed with any type of headache disorder, that being a main symptom within concussion injuries. We want to know, has there ever been diagnosed with learning disability or dyslexia, ADHD, or any type of other depression, anxiety, or psychological disorders? And there's indications there in those comments and current medications that they can put down. Also, in this section, step two, it's a symptom evaluation. This is huge for conducting a proper SCAT6 and also coming to a conclusion of whether or not you want to diagnose a concussion. So as you can see at the top, there's a couple boxes that you can check. Is this a baseline or is it following a suspected post-injury? Also, if it's indicated as suspected post-injury, you need to put what time elapsed since the suspected injury. And as we always say, you should never go off of the instructions. So you should always read the instructions in their entirety to the athlete. So since this is a suspected post-injury, you would go, please rate your symptoms below based on how you feel now, with 1 representing a very mild symptom and 6 representing a very severe symptom. So moving into what our athlete said. So step one, the athlete background, they indicated no for hospitalized for head injuries, no to headache disorders, no to learning disabilities, no to ADHD, and no to any depression, anxiety, or psychological disorders. There's no need for notes, and there was no current medications. Moving into our symptom score. And this can be given to the athlete and monitored by the clinician. They can fill it out and then give it back. Or it can be orally said to them by the clinician, and the patient can just respond by saying a number between 0 and 6. As you can see indicated on our score sheet, the total number of symptoms was 6, and symptom severity score was 12. And the reason we got that is because there were 6 different symptoms that they indicated that they had, and there was severity of 12 when added all together, those 6. Now, moving to the questions to rate. Following the symptom score, you want to ask the patient, do your symptoms get worse with physical activity? Indicating yes or no, and they indicated yes. Do the symptoms get worse with mental activity, i.e. homework, thinking about things? The athlete indicated yes. Now, the athlete also needs to be asked, well, how do they feel out of 100%? And this is a difficult question for some people to answer because it's not always asked. But a good way to explain it is that 100% feels like your best day. There's nothing wrong. There's no anxieties. What do you feel in comparison to that right now in this moment? Our athlete indicated 85%. They explained it that they can tell that something is off because of the injury. Moving on to the off-field assessment, step 3. So the evaluation begins with an orientation section. So this assessment tests the patient's ability to kind of answer basic orientation questions that shouldn't be out of the realm of normal understanding. And this assessment kind of helps clinicians assess for whether or not the patient is suffering, like as we've talked before, with retrograde amnesia or any other type of concussion-related symptoms or ailments. So as you can see with our patient, we asked them what month it was and they responded correctly. We asked them what day it was and they responded correctly. What day of the week? They answered correctly. What year it was? They answered correctly. And also what time it was. And they answered within the hour, so they got a 1 for that too. And the overall score would be a 5 out of 5. The next part, step 3, it's the immediate memory section. This will test the patient's ability to follow in different directions, which is difficult at times following an injury, and also recall what was told to them, i.e. the words that we're going to say. So this one is very important to follow the directions and read them out loud to the patient and make sure that they understand them. So moving on to what we did with our assessment. As you can see, I'll read the directions. The clinician would go and look at the patient and say, I'm going to test your memory. I will read you a list of words, and when I'm done, repeat back as many words as you can remember in any order. As you can see indicated on the sheet, we use list A. So as a clinician, you would go jacket, arrow, pepper, cotton, movie, dollar, honey, mirror, saddle, and anchor. And for trial one, after you repeated those words, the patient would read back as many as they can remember. As you can see indicated underneath the trial one section, the patient got jacket, arrow, pepper, movie, honey, and that was it. We indicated a score of 5 as a clinician, and we move on to trial two. We would repeat those same words and we do the same scoring. As you can see, they did significantly better on trial two with a score of overall 9. We do it a final time for a third time. And as you can see, they got a final score of 6 on that third trial. Overall, their immediate memory score was logged as a 20 out of 30. And you make sure to clock the time at 7:35 p.m. because you will be using these words again, indicated further in the assessment. So off-field assessment, step 3. So concentration is the third assessment tool used. This will test the patient's ability to listen, interpret, and recall numbers that are told to them by the clinician. The clinician will also test the patient's ability to recite the months of the year also in reverse order. So again, very important. As a clinician, we're going to read the directions word for word because we want the patient to understand. So moving to our clinical exam that we completed. We would read to the athlete, to the patient, I'm going to read a string of numbers, and when I'm done, you repeat them back to me in reverse order of how I read them to you. For example, if I say 719, you would say 917. So if I said 968, you would say, and the athlete would return with 869. So moving on to what we found. As you can see indicated, in the first top boxes underneath list A, our first one was 493. The subject got it correct and is indicated with a yes. The second one they were given under list A was 629. Also got it correct, indicated with the yes circle, and they got a 1 score on the first section. We continued to complete this exam until we reached the third box on list A section. This is a total of 5 numbers read out loud to them. They got both of those incorrect. They got a score of 0 and 0, and the scoring ended and the test ended. The digit scores they ended up getting was a 2 out of 4. The final thing on step 3 that they completed was the months in reverse order. So as you can see in the directions say, the clinician would look at the patient and say, now tell me the months of the year in reverse order as quickly and accurately as possible. Start with the last month and go backward. So you would say December, November, and go ahead. When our athlete and subject completed this exam, it took them exactly 11 seconds, as seen with our stopwatch on our phone, and they completed a total number of errors of 1. Overall, their month score was a 0 out of 1 because they got an error while completing it. Their concentration score was a 2 out of 5 total when combined with the month score and digit score. Step 4 of the off-field assessment. This section will test the patient's coordination and balance as indicated with the title. This is a series of different exams, including a double leg balance, single leg balance, and tandem balance. The patient is scored based on how well they're able to maintain balance during a 20-second interval. First things first, you should indicate what foot will be tested. And you need to ask the athlete, can you tell me what your non-dominant foot is? If they're not aware of what non-dominant foot means, or they don't know which one that is, you would ask them, if I were to roll a ball to you, which one would you kick? Which foot would you use to kick it? Once you found that out, you indicate by checking the box. You also indicate what testing surfaces you're using and what footwear is being worn. Moving on to the actual exam. You'll have the individual start with the double leg stance. As you can see in the bottom left picture in the graphic labeled A, that is the double leg stance with hips Hands on hips, ankles touching, feet facing forward, eyes facing forward, head facing forward. You will ask the patient if they're ready. They will indicate yes, and then you will say, close your eyes, and I will let you know when you have finished. You will let 20 seconds go by, and you will make sure to observe any errors that are committed. Once the 20 seconds has ended, you will document the amount of errors. Then you will move on to the next exam. The next one is tandem gait. As you can see in the infographics, see the patient standing heel to toe and the same hands on hips, eyes forward, stance. They will complete the exam. When the clinician says, ready, set, go, they will close their eyes and complete it in 20 seconds with the clinician counting the errors. Finally, the last exam will be the single leg stance. The patient will stand single leg, one leg up, hands on hips, head forward, and when indicated to close their eyes, they will. 20 seconds will pass and errors will be counted. As you can see for our exam, the foot tested was the left foot because it was non-dominant. It was tested on a hard floor, and the individual was wearing socks. They scored a 1 out of 10, having one error on the double leg, 3 errors on the tandem, 3 errors on the single leg, for a 7-error total out of 30. There was no modified best use on the foam because it was one unwarranted for the time. Off-field assessment, step 5. Delayed recall. This section tests the patient by having them attempt to recall the words that have previously been memorized. As you can see, the time started should be indicated, and also the list that was previously used. You will look at the patient and you will say, do you remember the list of words I have read a few times earlier? Tell me as many words from that list as you can and remember in any order. Once again, they don't have to repeat it in the exact order as it was before. This time they can just remember and recall as many as they can. Our patient successfully had jacket, arrow, and pepper, along with dollar, mirror, and anchor, for a total of 6 delayed recall score. Their total cognitive score. So the clinician will combine scores from these sections: orientation, immediate memory, concentration, and delayed recall. And finally, at the end, the clinician will also subjectively answer about the patient's overall demeanor, as seen with if the athlete was known to you prior to the injury, are they different from the usual self? As you can see, our patient scored a 5 out of 5 for orientation, a 20 out of 30 for immediate memory, 2 out of 5 for concentration, 6 out of 10 for delayed recall, and 32 out of 50 for their total cognitive score. The clinician indicated yes, that the athlete was acting differently from the usual self. Finally, the decision section. Following the conclusion of the testing, the clinician will add the corresponding scores to get a total. The clinician will use judgment based off the scoring and the overall demeanor of the athlete and situation. So as you can see from our scoring, the day was indicated that the injury happened. The clinician noted normal under neurological exam. The symptom score, the symptom number specifically was 6 as scored before. The severity was 12 as mentioned before. The orientation was a 5 out of 5. Immediate memory, 20 out of 30. Concentration, a 2 out of 5. Delayed recall was a 6 out of 10. Cognitive total score was 32. The balanced best was 7 out of 30. Tandem gait's fastest time was 15, and dual task wasn't tested due to not having to be done. Overall, the concussion diagnosis was yes, based off of these scores and overall procedures. And a return to play will begin once the patient is symptom-free. Finally, the healthcare professional attestation. It is important to complete so that proper legal standards can be kept, and it helps also maintain records for future use when needed. The following clinician would obviously put their name as listed, signature, and the title specifically to who they are, along with their registration, license number, and the corresponding date that all this happened. Overall, this is my SCAT6 presentation. Thank you.